Hello everyone. In the principle of management for thalassemia major, today I am going to cover treatment of complications. So what are the various complications occur in the thalassemia major? Disease related complication, transfusion related complication, then iron overload related complication. Then when you start the iron chelators, then its side effects and toxicity related complications. So I will go one by one. In disease-related complications, thalassemia patients are having the growth retardation because of chronic anemia. Deformed facial bones known as chipmunk face or thalassemic facies due to extramedullary hematopoiesis. Marked hepatosplenomegaly also developed due to extramedullary hematopoiesis. Hypersplenism and abdominal symptoms develop due to massive splenomegaly. Splenic infarct occur due to chronic hemolysis. Secondary hemosiderosis occur due to increased iron absorption in the GIT because of chronic anemia. They can also develop the pulmonary hypertension due to chronic hemolytic anemia. Free hemoglobin, when RBC will be lysed, this free hemoglobin inactivate the NO, and NO act on the pulmonary circulation to vasodilate it. So in the inactivated form of NO or deficiency of NO will lead to the pulmonary hypertension by the pulmonary vasoconstriction. Also because of oxidative stress of the free iron lead to the pulmonary hypertension. So all these contribute to the pulmonary hypertension. Even overt heart failure occur because of high cardiac output state, and also because of iron overload lead to the cardiac changes, and patient can develop the CCF in thalassemia. They can develop the jaundice because of hyperbilirubinemia due to chronic hemolysis. Gallstone because of hyperbilirubinemia can occur. Even the osteoporosis or pathological bone fracture occur because of calcium vitamin D3 deficiency. Even thrombosis can occur because hypercoagulability is there in the thalassemia patients. They are prone for the infection in the first decade of life because iron overload lead to the oxidative stress, and also hypersplenism lead to the neutropenia. Leg ulcer can also develop because of thrombosis and hypercoagulability. Endocrinopathies can develop in the first or second decade of life because of endocrine damage due to iron overload. Delayed puberty is because of endocrinal changes can occur in the thalassemic patients. Now, in the treatment for the disease-related complications, we should give the regular blood transfusion at 2 to 4 weeks interval. So, to maintain the hemoglobin at least 12 gram per dl, and pre-transfusion hemoglobin should be maintained between 9 to 10.5 gram per dl. Growth and development should be assessed at every visit or at least 1 to 3 months interval. 3 monthly serum ferritin should also be sent. Whenever you find serum ferritin level is more than 1000 nanogram per ml, iron chelator should be started. And deferasirox is the first iron chelator we should start. Annual cardiac T2 MRI, ECG, tissue Doppler echo or low dose vitamin stress echo should be performed annually after the age of 8 in thalassemia patients. Whenever there is a changes of cardiac iron overload, combination iron chelation therapy should be given. At least 2 iron chelators should be given. Annual parathyroid hormone, calcium level, phosphorus level, 25 hydroxy and 125 hydroxy vitamin D3 level DEXA scan should be performed for the osteoporosis, rickettsial changes, scoliosis, spinal deformity, which are common in the thalassemic patients. And if the patient is having changes of nerve compression or fracture, then all these tests should be performed. Annually, we should screen for all these complications by these tests. And for the prevention of all these complications, regular exercise should be advised. Diet rich in the calcium vitamin D3 should be advised to the patient. Calcium vitamin D3 supplement should be given. If changes of osteoporosis is there, then calcitonin, which is the inhibitor of osteoclast, hydroxyurea and biphosphonate should be started. Annual testing for FSH, LH, testosterone, estradiol should be performed after age of 12 years for the screening for delayed puberty. If you find any alteration is there, then hormone replacement therapy required for the endocrine abnormality. Now the transfusion related complications. So in transfusion related complications, there are non-infectious complications and infectious complications. So in the non-infectious adverse transfusion reaction, again categorized into acute reactions and delayed reactions. Whenever occur within 24 hours after transfusion, we label as a acute transfusion related reaction. We label if reaction occur after 24 hours delayed. Then again categorize into immune mediated and non-immune mediated, similarly in the delayed type of transfusion reaction. In acute immune mediated non-infectious adverse transfusion reaction, patient can develop the acute haemolytic transfusion reaction AHTR, in which according to the severity patient can develop the mild symptoms or moderate or severe. So in mild hemolytic reaction, patient will have the urticaria, rashes and itching. If patient is having moderate reaction, then patient will become restless and fever will also be there. If severe category of hemolytic reaction occur, then tachycardia, tachypnea, dyspnea, even hypotension, acute renal failure, DIC, or even patient can go into the shock and even death can also occur. So reaction severity will depend on how much reaction is occur in the body. This is the classical triad of the severe reaction. So patient will have the fever, kidney pain and hemoglobinuria. This reaction occur because of increased RBC destruction due to interaction of the recipient preformed antibody with the donor red cell antigen, resulting in immediate destruction of the transfused red cell. It is because of minor blood group incompatibility. For ABO and RH, they are doing the compatibility test, but for minor blood group in each and every blood bank, this facility is not available. Minor blood group, example Kale, Duffy, all these are the minor blood group antigen. So for this, patient may be having the incompatibility and patient can develop this reaction. It is also known as alloimmunization. For the treatment of acute hemolytic transfusion reaction, immediately stop the blood transfusion. Send the post-transfusion blood sample and also send the bag and tubing to the lab. There is a no specific treatment. We have to monitor the vital every 10 to 15 minute interval. We have to mainly resuscitate the patient by fluid therapy. And we should target the diuresis urine output at least 0.5 to 1 ml per kg per hour. Antipyretic antihistaminic given for the symptomatic treatment. We should maintain the normokalemia pH, urine pH should be more than 6.5, BP should be maintained by the fluid and inotrops. Platelet should be more than 20,000 and fibrinogen should be more than 100 milligram per dl. If platelet are less than 20,000 and fibrinogen less than 100, that means patient is going into the DIC and we have to give these components RDP and FFP. There are some drugs under the trial, ruxolitinib and eculizumab. We can give for severe case, and continuous hemofiltration or plasma exchange can be done whenever there is a severe category of hemolytic reaction. Now in the acute immune mediated reaction, patient can develop the simple allergic reactions. These symptoms may be either occur within seconds, minute or hour after the starting of the transfusion. So patient can develop the urticaria, which is the mildest form and it causes the itching also. In more extensive reaction, patient can develop the angioedema or anaphylaxis is the most severe in which patient can develop the severe hypotension and loss of consciousness can also occur. For the treatment of allergic reaction, similarly we have to stop the transfusion. We should send the blood sample and bag and tubing should be sent to the lab, monitor the vitals, antihistaminic for the mild reaction, adrenaline for the anaphylaxis, or we can try the methylprednisolone or prednisolone for the severe case. In immune-mediated acute reaction, patient can develop the febrile non-hemolytic transfusion reaction. So in febrile non-hemolytic reactions, these are the most common reactions. So allergic reactions and febrile non-hemolytic reactions are the most common transfusion reaction, in which rise in the temperature of at least 1 degree centigrade with chills rigor during or shortly after transfusion occur. This is cytokine mediated systemic inflammatory response which lead to the fever. For the treatment of febrile non-hemolytic transfusion reaction, similarly we have to stop the transfusion. Post-transfusion samples, bag tubing should be sent. Empirical antibiotic we can start if you find in post-transfusion blood sample patient is neutropenic, and also we have to send the blood culture. Antihistaminic we can give for the mild allergic reaction. Antipyretic can be given for the fever. For the prevention of this reaction, leukoreduction or washing of cellular products should be done. In acute immune-mediated reaction, patient can develop the transfusion-related acute lung injury. It is because of the antibodies in the blood donor, which reacts with the antigen in the recipient. Then recipient immune system causes the release of mediator, which lead to the pulmonary edema. So whenever there is a new onset or worsening of pulmonary function occur after transfusion, we should suspect transfusion related acute lung injury. Patient can have the hypoxemia due to the acute lung injury. So PaO to FiO2 ratio will be less than 300 mmHg. Chest X-ray will show the pulmonary edema, and these reactions generally occur within 6 hours of transfusion. So for the transfusion related acute lung injury, treatment will remain same. We should discontinue the transfusion. We should send the blood sample and bag tubing to the lab. Patient should be keep on respiratory support, oxygen therapy or mechanical ventilation with protective lung ventilation strategy. IV fluid, adrenaline, antihistaminic should be given to the patient. There is a controversial role of diuretic, steroid, albumin and statins. So these drugs should not be given to the patient because it can harm the patient. In acute non-immune mediated transfusion reaction, patient can develop the transfusion related sepsis. So at least one of the following features patient can develop within 90 minutes of transfusion. So fever more than 39 degrees centigrade or 102 degree Fahrenheit, rise of more than 2 degree centigrade or more than 3.5 degree Fahrenheit from the baseline, with or without chills, rigor, tachycardia, or change in systolic blood pressure either decrease or increase. We can label as a transfusion related sepsis. We should discontinue the transfusion. Post-transfusion blood sample, bag and tubing should be sent to the lab. We should start the oxygen support. Fluid should be started. We should also start the empirical antibiotic and send the blood culture. Antipyretic for the fever, adrenaline and antihistaminic can be given. Patient can develop the transfusion associated circulatory overload. So new onset of respiratory symptoms within 6 hours, elevated natriuretic peptide and signs of left heart failure, and radiological evidence of pulmonary edema will be there. We should do the same thing as in previous. Keep the patient on respiratory support, oxygen therapy or mechanical ventilation with protective lung ventilation strategies. Diuretics are effective whenever there are signs of circulatory overload. So furosemide should be given. Patient can also develop the citrate toxicity if large volume of blood is given to the patient. Because increased plasma citrate chelate the calcium ion, patient will develop the hypocalcemia because of citrate toxicity and symptoms of hypocalcemia will occur. Transfusion associated hyper and hypokalemia both can occur. Hyperkalemia because of RBC lysed and potassium will be released and its level will be increased. Hypokalemia is more common than the hyperkalemia. It is because donor red cell reaccumulate the potassium ion intracellularly, and also citrate metabolism causes a further movement of the potassium into the cell. So patient can develop the hypokalemia also. Coagulopathy, hypothermia, air embolization can also occur due to blood transfusion. Now in the delayed immune-mediated reaction, patient can develop the delayed hemolytic transfusion reaction in which ALO, autoimmunization, hemolytic reaction, anaphylactic reaction all can occur. Alloimmunization means patient is having antibody to the foreign red cells. Whatever RBC we will transfuse, patient is already having the antibodies to these. Example, minor blood group incompatibility occur and lead to the alloimmunization. Autoimmunization means patient is developing the antibody to the own red cell antigen. So destruction of own RBC occur in autoimmunization, while in the alloimmunization, destruction of the donor RBC occur. Now the patient can develop the transfusion associated graft versus host disease in delayed immune mediated reaction, in which patient will have the fever, rashes, or rashes can be maculopapular, which can progress to the bully formation, enterocolitis with watery diarrhea, altered liver function test, pancytopenia, all can occur. This reaction generally occur after 8 to 10 days of transfusion. Now in the non-immune mediated reaction, patient will have the iron overload. So whenever patient is chronically regularly transfused in the thalassemia major, transfusion dependent thalassemia, patient will develop the iron overload. A unit of RBC contain 250 milligram iron, and when RBC will be destroyed, released iron is stored in the body as a hemosiderin and the ferritin. After 10 to 15 unit of RBC administration, iron will accumulate in the reticuloendothelial system, liver, heart, spleen, endocrinal organ. And this deposited iron causes the tissue damage which lead to the heart failure, liver failure, diabetes, hypothyroidism, various endocrinal problems. Now in the infectious risk or infectious complication of the transfusion, various transfusion transmitted infection can occur. Hepatitis B, 1 in 1 to 2 leg transfusion. Hepatitis C, 1 in 1 to 2 million. HIV incidence, 1 in 2 to 3 million. Yersinia, malaria, CMV, parvovirus, dengue virus, various other bacteria, virus and parasitic infections can occur. So for the prevention of infection, proper donor selection should be done. Screening for HIV, HPS, HCV should be done. Malaria should be prevented. For CMV, leukodepleted RBC should be transfused. Whenever there is a Yersinia, stop the Desperal and initiate the antibiotic for Yersinia. Always thalassemia baby should be vaccinated for the hepatitis B vaccine. After the disease related and transfusion related complications, patient will develop the iron overload related complications. So in iron overload, we label as a secondary hemosiderosis, which is because of increased iron absorption in the GIT due to chronic anemia and increased erythroid drive. Transfusion induced hemosiderosis occur because 1 ml packed red cell contain the 1 milligram iron, or 1 unit of RBC contain 250 milligram iron. So patient is not having the sufficient excretory mechanism for the excess iron in the body. So excess iron deposited in the reticuloendothelial system, liver, spleen, and in endocrinal organ and cardiac tissues. So initially iron deposited in the liver lead to the chronic liver failure cirrhosis. Then it is deposited in the endocrine organ and heart. Ultimately, patient will develop the endocrinopathies. Example, diabetes mellitus, hypothyroidism, hypoparathyroidism, hypogonadism. And because of deposition in the heart, patient can develop the arrhythmia. Iron is deposited in cardiac myocyte due to chronic transfusion, which disrupt the cardiac rhythm. Left ventricular ejection fraction is decreased. Iron is deposited in the heart, lead to the congestive heart failure. Chronic iron deposition due to multiple transfusion can also lead to the bronze skin color. Even iron is accumulate in the substantia nigra. So patient can develop the early onset Parkinson disease or psychiatric problems can occur. Hepatosplenomegaly, huge hepatosplenomegaly, massive splenomegaly is the result of chronic iron deposition also. So for the prevention of iron overload related complication, we should start the iron chelator whenever patient is having serum ferritin more than 1000 nanogram per ml. We should go for T2 MRI for the cardiac iron overload status. Annually, we should perform in more than 8 years age group. R2 or T2 MRI for the liver iron should also be done. Annually, glucose tolerance test, fasting and postprandial blood sugar after the 5 years of age annually should be performed in the thalassemic patient. Annually, thyroid function test, parathyroid, calcium phosphorus, 25 and 125 hydroxyvitamin D3 level should also be performed for the changes of parathyroid gland and these. Annual serological testing for the FSH, LH, testosterone, estradiol should be done after the onset of adolescent after 12 years of age. Now the last is iron chelator related complications, and this part is already I have covered in the previous video, so I'm not going to repeat it. So these are the complications in the thalassemia major. Thank you so much.